curve up here since we're still dealing with it. Again, this is oxygen percent saturation. Actually, well, it's hemoglobin percent of oxygen, right? And we'll break this up into 50, 25%, 75%, and 100% saturated. That's how much the four oxygen molecules can go on. This is going to be the partial pressure of oxygen, and it's millimeters of mercury. And again, we'll put this into terms of 25. Okay. Now, if I'm drawing this up quite often, and we're talking about this, there are going to be questions on the test. No doubt about it. Okay? So, what we have here, I'm going to use the same color so we can. Okay. Now remember, again, it's not a linear curve. A linear curve would mean that if we have, and this millimeters of mercury, you can think of this as percentage, how much percent of oxygen is coming into your body, all right? But it's not a percentage. It's millimeters of mercury. But if you want to picture the amount of oxygen coming in, you could picture it that way. So if we bring in, let's say, 20 millimeters of mercury, if it was a linear, I'm doing this because I really am emphasizing what this is. If it was linear, then when we have 25 millimeters of mercury, it will be 25% saturated, the hemoglobin. If we have 50 millimeters of mercury of oxygen, then you would have 50% of the hemoglobin saturated. And same thing with 75 and 100. This would make for a linear curve, but that's not what's happening, right? It's not straight like that. It has a curve to it. And it's because we have this thing called cooperative binding. To get the first oxygen on, in other words, for us to reach 25%, we have to put more pressure to get that first one on there, more concentration of oxygen. So we may have to get it up to, let's say, maybe, I'm just giving you numbers, let's say 35, and that'll bring it up to here, to 25%. But once that first one goes on, it's going to make the other ones come on much more rapidly. All right? I now use that stamp thing, right? You have the stamp over here. If we take the first one off, we're going to have to put more force, more effort to take the first one off because we have to break this bond over here and this bond over here. We've got to break two bonds to get that first one off. But because that first one came off, it's going to make the other two come off quite easily. You only need to break one bond here to take that stamp off. You only need to break this bond over here to take that stamp off. And the last one is much easier to do. It's cooperative. It's doing a cooperation. We have to allow that first one to come on, and the other two and three will be coming much easier. Is that clear about that? So once this one comes on, then the next one, you don't need to use that much pressure, that much concentration of oxygen to get the second one on. So this becomes steeper. And the third one, you don't need to get much more power over there, and you're going to go steeper over here. And then it starts going this way. So, color red. All right. So you get this kind of curve. Does that make sense? It's not linear. It's what we call sigmoidal, or more like an S shape. Okay?
So those dots are the concentration of oxygen?
I'm just giving an example that's over here, here, yeah.
Okay, okay.
Yeah. Okay? Is that clear about that? Yeah. This is the way we breathe. Like I said, when we have to deal, now we got to deal, if you understand this part, the practical use here is this. Let me give you the other curve, because this is not really drawn to scale. This is a good curve. What this is saying over here is that if we have, let's say, 20 millimeters of mercury here, it'll go up to, well, it says it here, 20 will give you 35% saturated. You're going to put more pressure to get that on it. Okay? But look what's happening here. If we go up to, let's say, 40 millimeters of mercury, at 40 millimeters of mercury, you're already at 75% saturated. You don't need, what I'm saying here is that you don't need to be breathing in 100 milliliters of mercury, of oxygen, to be almost fully saturated on your hemoglobin. You would think that, oh, I got to make sure I'm breathing 100% of oxygen. No, you don't need that. It gets capped off. For instance, if I was going to breathe in, let's say, we'll say 70%, we'll say percent, but it's millimeters of mercury. So if we bring in, let's say, a concentration of 70 millimeters of mercury of oxygen, 70 is going to get me to about 93% saturated on the hemoglobin. So what kind of a change if I go from 70 and I start breathing in, let's say, 100? If I'm already at 93%, it only goes up to, never make 100%, but it goes up to 97%. So small increases is not going to do much when you breathe in there. It gets capped off. You see that? That's an amazing phenomenon. Okay? Now, what we've been talking about is this curve, but a shift to the right and shift to the left. That we can actually have, and I want to get this color straight, a shift to the right and we could do certain things to make it a shift to the right. What this means is that there's going to be, if there's a shift to the right, then you're going to need more oxygen, more pressure of oxygen for it to actually be bound to hemoglobin. So therefore, if it can't bind to hemoglobin, the oxygen that's on the hemoglobin is going to fall off. See what's happening? That oxygen wants to get released because the magnet between the oxygen molecule and the hemoglobin are not strong. It's going to fall off. So if there's a shift to the right, then oxygen is going to get released. And there's certain factors, as we've been talking about, pH, temperature, the amount of carbon dioxide, and a few more that we're going to go over, is going to change this curve and make it shift to the right, or we're going to make it shift to the left. Now, shift to the left, you don't need much pressure, oxygen pressure, to have that oxygen be bound to the hemoglobin. It wants to stick there like super glue. Oxygen doesn't want to come off. It's hard for it to come off. Does that make sense? All right? So we have certain things that we've been talking about. If we increase pH, meaning it's going to be more alkaline, it's going to be a shift to the left. But think about what's happening here. As I talked about before, you're running a So we want to make sure that this oxygen comes off the hemoglobin quite rapidly to go to the cells, to go to mitochondria and make ATP. So we got to create an environment that is going to make a shift to the right when you're running a marathon, so that this oxygen can come right off quite easily, so that you can make more ATP to continue your running. So you're running. Are you getting hotter?
Yeah.
What's your temperature doing?
Going up.
Sure. So if your temperature goes up, you're going to have a shift to the right. If you're running and you get that pain, that pain is from what? A byproduct called lactic acid. What happens to the amount of hydrogens with lactic acid? Does it go up or down? It goes up. So an increase in hydrogens is also going to give you a shift to the right. If you have lactic acid, what happens to your pH? It goes down. So when your pH goes down, you will also get a shift to the right, to allow that oxygen to come off quite easily. And that's what the significance of this whole thing is. We just, as laymen, we just breathe in and out. But now with anatomy and physiology, we need to understand, well, why is it that we are not keeling over and not gasping for breath? Because we have this oxygen dissociation curve going on. This is physiology. You will be using this stuff later on, especially if you're going to respiratory therapy. This will be the bread and butter, right?
Are we gonna have spoon showing that?
Excuse me?
Are we gonna have spoon showing that on the patient?
No. You just need to understand the concept of it. They'll be using that later on by saying, oh, that's a shift to the right or left. Well, you could draw it so that you could understand it. You would never do this for your patients, though. But when you talk to other colleagues, if there's something like that, especially respiratory therapy, yes. But you might not have to draw this. You'll just say shift to the right, shift to the left on the oxygen dissociation curve, because everyone will be on the same page with you. This is one of the toughest things to get to understand when it comes to respiratory physiology. Okay? And these are the factors that at least we're going to go over, or we have already, that are going to change this. Whether it's going to give you a shift to the left or shift to the right. Whether we change the temperature. If we decrease the temperature, we're going to have a shift to the left. Is that clear about this? Okay? So remember, shift to the right is that oxygen wants to get released. And my little mnemonic on this is that think of that plane that the Wright brothers have, that weird looking plane, and think of the Wright brothers dropping off oxygen tanks. They're releasing oxygen because it's a shift to the Wright brothers. Does that make sense? And for studying purposes, should you come up with something as a mnemonic for the left shift? No, don't waste your time on it. If you know for the right shift, then you know it does the opposite for the left shift. Okay? And that's what's explained on here. Again, the word affinity means attraction. So there's less of an affinity, there's less of attraction of oxygen bound to hemoglobin, so when there's a shift to the right, oxygen will fall off. Okay? Questions about that? All right? And then we talked about the amount of carbon dioxide. I'm not going to go through that again, how that changes things. We did this whole carbonic acid reaction. At the tissue levels, we talked a little bit about the chloride shift, all right, and what happens at the tissue level versus the lung level, or the alveoli. And then again, that was the chloride shift. Okay, there too. And it's this whole reaction that we're going to go more into. When we get to urology, we'll talk more about this too. And we'll talk about the Haldane effect and the Bohr effect also. Okay. And then we talked about pH, which I just briefly summarized for you guys. Talking about the Bohr effect, and how the Bohr effect and the Haldane effect, how they work with each other, but they are different things. This little saying over here, put that in perspective. All right. And we talked about temperature. You know, if you increase your metabolism, you're going to increased energy, which means you're going to produce heat, which means that your body's going to have a shift to the right, right? Okay? And this is in picture form what that all is. All right. Now we're all caught up. Okay? Now we deal with something called BPG. For the most part, most of you have probably never heard of this, but it is a big concept we have to do. This is 2,3-bisphosphoglycerate. You don't have to worry about spelling that. All right. Most people refer to it as BPG or DPG because B stands for bi, meaning two, but some people use di for two, so they can call it DPG. So DPG or BPG is the same thing. All right. Let me just explain what this is. BPG is this chemical that gets released from red blood cells during breakdown of glucose. Okay? And what happens here is that we have a decreased amount of oxygen, partial pressure of oxygen, as we go up in altitude, right? You go to Mount Everest, all the way to the tippy tops of Mount Fuji and stuff. There's less atmosphere up there, there's less oxygen up there. So there's a decrease of oxygen as you move up. Is that clear? Right? So living at high altitudes is going to produce or secrete more BPG, okay? And BPG is reversibly bound to hemoglobin. So if you have, let's say this is a red blood cell with hemoglobin, if we're going to put BPG on here, on the area of hemoglobin that oxygen wants to be bound to, then what's that going to do to oxygen? Oxygen that was on here is going to come off because BPG is now replacing it. So what happens here is that when you have areas of your body getting a lot of BPG, you're going to make oxygen get released. Is that clear? So, at high levels of BPG in your body, would you expect a shift to the right or a shift to the left? We're going to release oxygen with the high amounts of BPG. Shift to the right. Okay? And that's just what it's supposed to do. That's the significance. If you're going in an area that has less oxygen on there, which is up in the mountains, you would expect that your body should release more oxygen off your hemoglobin to get into the cells because I can't get it out in the atmosphere. So whatever's on my hemoglobin better come off, otherwise I'm going to suffocate up there because there's no oxygen. It gets to a point where you're going to acclimate, and we'll talk about acclimation. It takes about a week and a half for your body to acclimate to the issues that you have up there. But that's what's happening. You want the oxygen to come up. You don't want to hold it on because you can't get it in the atmosphere. So whatever you have on reserve better come off. So your body makes more BPG, and that's going to knock off oxygen, get released from your hemoglobin. Okay? Clear about that? Now, let's talk about the significance of oxygen and high altitudes. At sea level, now just think about this. At sea level, you're about 98% of your hemoglobin is saturated oxygen, all right? Close to 100, but it's not perfect. It's 97.5, it's 98, we'll say, okay? So look what's going to happen here. At rest, at sea level, where we are, at rest, when that oxygen goes on our hemoglobin, it's going to be 98% saturated, and it's going to go, that hemoglobin is going to go around your body and come back up. At rest, only 25% come out for that one cycle. So when it returns to your heart, or to your lungs, the hemoglobin has now lost 25%. Does that make sense? You can hold your breath. You're allowed to hold your breath because you got 75% still on your hemoglobin. Now, if you're running a marathon, you're not going to have 25% come off. You'll have more like 50%, 60% coming off. Try and hold your breath then. You don't have much oxygen on reserve on your hemoglobin. You can't do that. So at sea level, if you already have, let's say, 90% hemoglobin saturated at the lung level, by the time it returns through venous full blood, we've lost 25%. That leaves us with 73% left on it, 73, 75%. Does that make sense? Is that clear before I go any further? Because now we've got to apply this. Now, what happens when we move up in altitude? Okay, we're at sea level, and then we're going to drive or fly up to the Alps over there, and now the atmosphere is different. The oxygen in the atmosphere is going to be much lower. So we move up about 19,000 feet above sea level. And at that point, there's less oxygen. So now the breathing that you're doing is only going to make your hemoglobin at the lung level only 67% saturated. Not the 98 that you do at sea level. It's much lower. Now, you're still going to lose 25% because you're doing resting up there also. But look what happens. You start off with 67%, you lose the 25%, and now what you have on reserve is only 42%. You can't hold your breath very long up in the Alps that you can here in the sea level. Do you see that? Do you see how this is significant? Well, the Olympics changes things. Well, for the Olympics back in 1968, they didn't realize this. The Olympics in 1968 were in Mexico City, and it's on a higher level. So this is what was happening. People who were training at sea level, whether Jamaica, wherever they are, they've now said, you know, today's, let's say, Wednesday, you know what? The Olympic that I got to do, my main event is going to happen on Saturday. So I'm going to fly up there today. I'm already trained and stuff. I'm going to fly over there today, and I'll be able to run the marathon that I usually do. You can't, because you were training at sea level, and now your body didn't acclimate in 2 to 3 days. You're now going to be breathing, instead of 98% saturated, you're going to only be 67% saturated. You're not going to have much on reserve. So these people were going to the hospital because they couldn't manage to run that track that they were used to doing. And that's what was happening. Look it up. It's the 1968 Olympics. We saw a lot of people not dealing with that. They didn't think anything of it. So that's the significance about this. Okay? Questions about, do you understand this concept? All right? We'll have questions on it. Okay. So, acclimatization, we've been talking about that. What does that mean? How does your body acclimate to this higher altitude? Okay? A lot of things happen. When you go to a higher altitude, there's less oxygen in the atmosphere, so therefore you're going to have lower arterial partial pressure of oxygen on your blood. Just going to happen, there's less out there. So if you have less oxygen coming in, then your body's going to say, whoa, less oxygen, that means we need to make more red blood cells. That's what it is. Erythropoietin, going back to hematology, you know how it works. We got to bridge things from before. Erythropoietin is a hormone that comes out of the kidney, and it gets stimulated to get secreted when you have low levels of oxygen in your body. When you move up there, there's less oxygen coming into your body, so therefore your body is going to make more erythropoietin, which means you're going to make more red blood cells. Does that make sense? All right? That's what's happening with that. When you decrease the amount of oxygen in your body, it's going to send a message to the chemoreceptors that are in your brain. We call them central chemoreceptors. And they're more responsive to the high levels of PCO2 that are in your body. We'll talk about that, I guess, next week. The decrease of arterial partial pressure of oxygen is also, as you just saw, it's going to increase BPG, which means it's going to help to get that oxygen, whatever's on the hemoglobin, to fall off. Because there's less oxygen out there, we need to get more oxygen into our cells. So BPG is going to do that. And when you have really low levels, if you're going way up there, your levels of O2 are going to be dropping astronomically. And this will just not stimulate up here the chemoreceptors. It's going to start stimulating down here. And we'll talk about that more. All right, the peripheral chemoreceptors. But all of this that I just talked about is going to increase ventilation. You will tend to hyperventilate as you go up in the Alps over there, because your body is adapting to it. Now, when I say hyperventilating, you might not see it, but normally, if we're breathing like this, you might see it a little bit faster. But your body is adapting to that. You're not saying, man, I can't breathe well. Your body adapts to it, or acclimates. That's what we call acclimatization, okay? And it does that to try to bring in more oxygen into your body, whatever's out there, and also to try and get rid of the CO2. Okay? So when you hyperventilate, you're going to decrease the amount of CO2 that's in your blood. You're going to blow it out. And that whole carbonic anhydrase reaction that we've been talking about, where CO2 and water will end up making hydrogen and bicarb, that's what's going to happen over there. Okay? So this is a long-term thing that your body does. It takes a few days, maybe about a week or so, for your body to acclimate to this, so that you can be doing all the stuff that you normally do at sea level. And over there, your body has to adapt to this lower level of oxygen. And it does these things. All right? I'm not going to go through this. You can do this on your own. But high altitudes, everything I just talked about is over here, and how that does that. Okay? Now, this is just an interesting thing. As the RBCs, as the red blood cells start aging, right? How long does a red blood cell last? 120 days. Okay, it's about 4 months. When they start dying down, the levels of BPG also decrease. There's less on there. This is, so when you actually donate blood, we could actually have the blood expire, because they can only sit on there for 128 days or 120 days. So what we do is that we actually use the BPG as a marker. And we don't want to wait 120 days. They usually wait about a month and a half. When they get to a level that's whatever it is, at 6 weeks, that's when they say, we've got to just throw out the blood. Okay? Because once the BPG levels drop too low, then the oxygen becomes irreversible. It stays on the hemoglobin and it never comes off. And that's what happens with that. And it's useless to use for transfusions. So now you could probably understand a little bit about blood doping. All right? A lot of athletes would be trying to do this. You train an athlete in the mountains for 3 to 4 months. They're going to have erythropoietin coming out to adapt to that higher altitude with less oxygen. They have a lot more red blood cells in their body over there, which means it's going to increase BPG. And while you're up there, they take a pint of your blood out. It's your blood. It's loaded with BPG. It's loaded with red blood cells. They take a pint of it out of you, or 2 pints, whatever it is, and then they go down back to sea level about a week later when they have to run that marathon, and they transfuse and put a pint back of that blood in you. Well, let's say a month later, when your body acclimated at sea level, you're now getting your own blood, and it's loaded with BPG, it's loaded with red blood cells, which means you're instantly going to get this shift to the right, which means you're going to get this burst of oxygen coming off and allow you to do that sprint so rapidly. Does that make sense? That's what blood doping is. The problem is, that we talked about, is that if you add more red blood cells to the bloodstream, What is that condition called? When you increase red blood cells? Polycythemia. And what's our concern with polycythemia? It increases the viscosity, the thickness of your blood, and then we got to worry about astronomical hypertensive crises. And that's what we're concerned about. So that's why, so there's this controversy about that. It's not a drug like steroids you're putting in the body, it's your own blood. So there's things that they say you can't put anything into your body. There's certain laws that rules that you can't put anything in your body, no matter what it is. There's certain rules that just drugs. But we've also seen this with horse racing. Train a horse up there, bring them back over here, boom, and they could win the, because we're talking about millions of dollars that they could win. Or dog racing and stuff like that. Okay? So that's the whole thing about blood doping. And you've heard of blood doping, right? That's what it's all about. So fetal hemoglobin. See, we have an issue now with, let's say, a fetus where the lungs don't work. They're growing. The lungs are still immature. So any oxygen that the fetus gets from mom through the placenta has to be really bound to that hemoglobin in the fetus. We don't want it to come off very rapidly. We want it to stay on for a longer amount of time because you can't get a constant supply of it from the lungs all the time. We only have to rely on mom to give it. So what happens here is that when you have a certain type of hemoglobin, how the hemoglobin is, there's 4 chains. We talked about those, 2 alpha chains, 2 beta chains. Well, if, and I forgot it offhand, but if there's 3 beta chains or something like that, then that's not adult hemoglobin, it's fetal hemoglobin. And it makes oxygen be bound tighter to that. The affinity for oxygen is very high. The magnetism, the glue between oxygen and fetal hemoglobin is very strong. It comes off, but it's still strong. It's like stronger Velcro, if you want to say that. So in this case, if you increase hemoglobin of fetuses, then it's not going to be a shift to the right. It's a shift to the left. Because the hemoglobin and oxygen are so bound together there, like a magnet. Does that make sense? It's going to have a hard time coming off of the hemoglobin. So again, just showing here's adult hemoglobin in red, and you can see fetal hemoglobin is shift to the left. Okay? So this is a summary of all those different factors. There's the solid line is the one that's normal. Shift to the right. These are the things that happen. Increase of metabolic needs. Metabolism increases. You think about running a marathon. That's probably everything right there. You're running a marathon. You're expecting more metabolic needs to happen. More oxygen should come off. You're going to increase the PCO2 as you're using up all the if you use up all the oxygen, it's going to make ATP, which means it's going to be producing a lot of CO2. So it'll go up there. Your temperature will go up, all right? Your pH will go down because the hydrogens will go up because lactic acid and other things like that, all right? And like I showed you with altitude, as you go up, it'll also be a shift to the to the right, and also increase the DPG. The opposites would all cause a shift to the right. Shift to the left. Is that clear? But understand the concept. You're running a marathon. Everything is right there. If you understand that running a marathon, then you understand that it's all a shift to the right, where oxygen wants to come off. That's the benefit. Okay? Just a quick note about carbon monoxide. Carbon monoxide, that's that colorless gas, the odorless gas, the tasteless gas. That's the one that a lot of people have in their houses. You should have in your house about carbon monoxide that's coming into the house. We shouldn't have carbon monoxide coming from exhaust of cars. That's why you go for inspection, make sure the high dose of carbon monoxide is not coming off. But that's what that is. Okay? But carbon monoxide is that carbon monoxide, which is referred to as CO, mono meaning one oxygen, not CO2, which has 2 oxygens. when CO binds to, and I'll use the same picture here, but when it binds to hemoglobin, oxygen can't get on there. This carbon monoxide is so damn tight that oxygen just won't come on there. All right? Oxygen can't be bound to that because the carbon monoxide is so tightly bound to the hemoglobin. So we have a problem with this. That's what carbon monoxide poisoning is. The first thing you do if someone has carbon monoxide poisoning, you get them out of the place. Wherever it is, get them out of the place. Because he keeps on breathing this in. And what you do is, hopefully it works, but you load them up with high doses of oxygen. Big doses of oxygen. Bring 100% all the way. Hopefully that oxygen is so powerful here, and we got rid of this source of carbon monoxide. The oxygen is so powerful, we're hoping that it's going to knock off the carbon monoxide off the hemoglobin. So people are not so lucky. But that's the treatment for that. And their blood is this dark, dark brick red. And that's how you can tell with that. But it's this colorless, odorless gas that you really can't see. And that's what the curve looks like over here. Okay?
So if someone, if you were to find someone that, you know, had carbon monoxide poisoning and you brought them outside and you tried to resuscitate them, would it take longer to resuscitate them? Or
Yeah, because you're trying to put oxygen in them,
okay.
but that carbon monoxide depends on how long they've been in that area. If it's so bound over here, you get them out of the area, we're hoping that the oxygen that you have in your body is going to put it on his hemoglobin. But if he's in there for a long time, it's hard to get that carbon monoxide off. That's why you have those alarms. As soon as it goes off, you know, if you only want to have one alarm in your house, I would put it by the bedrooms. You know, that's where most people spend their time. You know, at least the kitchen windows are open and stuff, but I would put a couple of them. The most likely place it's coming from is your garage, but it could be in the air too. And also keep in mind too that carbon monoxide is also in cigarettes, so be careful with that one. At small doses, but you smoke like a pack of cigarettes, you're giving yourself a lot more carbon monoxide. So it says it when you get a pack of cigarettes. I'm not encouraging people to buy cigarettes. But if you can take a look at the side, it'll say contains carbon monoxide right on it.
So since we've already covered the basics of the hemoglobin dissociation curve, let's just talk about playing around with this line, and let's talk about left shifting and right shifting the blue line that you see right there. Now you're going to hear that terminology, a left shift and a right shift. But let's try to think about some of the things that cause changes in the behavior of hemoglobin. So we already talked about in the previous video how hemoglobin changes its behavior a little bit as a function or as oxygen levels change around it. Well, hemoglobin actually shifts to the left and right depending on some other things that are around it as well, pH, DPG, and temperature. And so if you see a decrease in pH, ask yourself right now, what does that mean? And we're telling you a decrease in pH at the tissues or in a capillary bed near the tissues. What does that mean? Well, it usually means that you have an increase in a metabolic rate, because usually you're going to see a decrease in the pH in tissues with a high metabolic rate. DPG is also something that's produced as an intermediate of glycolysis and represents a increase in the metabolic rate of the tissue. And a high temperature is also associated with an increase in metabolic rate. So these variables are really just telling you one thing, which is that there's an increase in the metabolic rate. So now pause the video in a second, but answer this question. How would you want hemoglobin to behave near or in tissues that have a high metabolic rate? Try to answer that question and pause the video right now. So hopefully you got to the idea when you thought about this that in high metabolic rate, when you have a really highly active tissue, your goal from the point of view of oxygen would be to enhance the delivery of oxygen. Now there are tons of different ways that you do this, but the way that hemoglobin actually behaves is that if it encounters an area where the pH is low, DPG is high, or temperature is high, it is going to right shift its curve. And let's look at what that means. It's going to now, instead of being the blue line, hemoglobin is going to shift to the right and become this red line. And let's look at how that changes its behavior. Basically, what that means is that you start to go downhill on this hemoglobin loading curve sooner. And remember, when you're looking at a steep region of a graph, that means that for a very small change in oxygen, you're getting a very, very quick change in the percent saturation, and it's going down. So the steep part of the line means that oxygen is jumping off of that hemoglobin. It really wants to leave. And so a right shift in the curve makes the downhill region happen sooner, meaning that over here on our blue line, it was at about 50 millimeters of mercury, where you started to really flow downhill, where hemoglobin started to kick off oxygen relatively easily. Well, if you right shift the curve, now that downhill segment comes earlier, which means that it takes you don't have to drive the oxygen level down quite as low in order to get hemoglobin to give off oxygen. And so really, we don't look at graphs that frequently in our daily life, but that's really what that right shift means. A right shift fixes the wrong. That's kind of how I remember it. The wrong is that, oh man, the pH is getting too low, the temperature is getting too high, DPG is being produced, meaning that our metabolic rate's really high. So if the hemoglobin's in a region where the metabolic rate's too high, you should shift the curve to the right, which makes it easier to release oxygen from the hemoglobin and ensures that you fix all these problems. So again, a right shift fixes a wrong. That's kind of how I remember it. But make sure you take a chance to write down this graph on your own, because when you're taking exams or trying to remember this information, the graph itself, by drawing these three lines on here, can actually really help you recall things. So practice drawing this graph so that when you get an exam, you can draw it right on the exam and you can remember it really well. Next video, we'll talk about a left shift.